So the next question, number 26. A patient is suspected of having obstructive sleep apnea. So he's asking here about obstructive sleep apnea. This is in the field of respiratory or respirology, respiratory medicine. All of the following would be consist with this diagnosis except BMI of 18.5. This is absolutely wrong. Why? Because BMI 18.5, this represents normal body mass index or more close to underweight. So this is usually obstructive apnea patient. They are obese. They will have either obesity grade 1 or 2 or 3, or at least they are overweight. So BMI of 18.5, it does not consist with this diagnosis. So hemoglobin 19.5, this is represent polycythemia, and this is expected with this type of patient. Why? Because these type of patient, they have chronic hypoxemia. This chronic hypoxemia will stimulate the production of erythropoietin from the kidney and from the liver, and this production of erythropoietin will stimulate bone marrow for production more red blood cell, and this will lead to polycythemia. This is called secondary polycythemia. Therefore, this is correct. This correct statement. This is associated with obstructive apnea. History of daytime somnolence. Yes, one of the common presentation of obstructive apnea, it is daytime somnolence, and the most common symptom is snoring. And the daytime somnolence is one of the other symptom. Neck circumference 41 centimeter, which is increased neck circumference. This is one of the criteria of the obesity, the increased neck circumference, and this is correct. And on antihypertensive therapy, usually these kind of patient, they have two types of hypertension: systemic hypertension and pulmonary hypertension, and therefore they are at risk of left side heart failure and right side heart failure, and they might end up with congestive heart failure or biventricular heart failure. So antihypertensive therapy is because they have sympathetic overflow. This sympathetic overflow and catecholamine release will lead to hypertension, and usually they have secondary hypertension. This secondary hypertension, it's indication for antihypertensive therapy. So the question number 27, 71-year-old lady was referred to vascular surface by her GP, general practitioner, with a complaint of painful toes that were dusky and blue in color. So dusky and blue in color, this represent signs of low perfusion to the toes, and it's painful. So she denies any pain in the calf on exertion. So she denies any pain in the calf on exertion. So she had no claudication, no signs of claudication. On examination, she had an obvious expansile pulsation in her abdomen. So here we have expansile pulsation in her abdomen. This represents sign of abdominal aortic aneurysm, and she is 71 years old, and this is usually in this age group, they might have one of the risk factor of abdominal aortic aneurysm. It is the age. So she was not complaining of abdominal pain. A duplex scan was performed, which revealed 4.6 centimeter of infrarenal abdominal aortic aneurysm. So the ultrasound showed 4.6 centimeter of infrarenal abdominal aortic aneurysm. What's the most appropriate next step for this patient? To do CT scan of angiogram, and the role of CT angiogram, this is to confirm diagnosis and to give more accurate reading about the size, and for pre-op and for planning for the surgery. This is the importance of CT scan of angiogram for planning of surgery, to know what kind of surgery we can do. Is it open, or for example, or it is EVAR, which is endovascular aneurysm repair, and the other things to make sure what's the accurate size, because the duplex, it will give you the size, but the accuracy in the CT angiogram is more. So to know what's the size and to confirm the diagnosis, and as a pre-op planning, we have to do CT scan of angiogram, and I think this is the most appropriate next step in the management of this lady. The other option to do straight away, to go to theater to do EVAR, I think this is it is unreasonable to do this. You have to do more investigation to know the exact site of the aneurysm and the exact size of the aneurysm So open aneurysm repair, this is as well, this is not a reasonable option. These we have to decide about EVAR or open after doing CT scan angiogram. Optimizing risk factor and follow-up with duplex scan in 1 year. I think we have to do CT scan angiogram, and according to the size of the abdominal aortic aneurysm, we will decide either to do for conservative management and follow-up and surveillance, or to do intervention. The intervention, either it will be EVAR or it's open aneurysm repair. So I think the correct answer is A, the correct answer. So let's move on to question number 28. A 26-year-old man is entered with central crushing chest pain. So central crushing chest pain, usually the most important differential of central crushing chest pain, it is ACS, which is acute coronary syndrome. But in this age group, it's unlikely to be acute coronary syndrome. So during an all-night party where he has been taking cocaine, so he is a drug abuser, he's using cocaine, he is an active smoker, and he is smoker. What is the most likely mechanism? He's asking about the mechanism of his pain. I think this question is connected with I think cardiology or cardiovascular studies. He's asking about the pathophysiology. How is that cocaine causing acute coronary syndrome? Is it cardiomyopathy, effect of cocaine in the heart and causing cardiomyopathy, or it's chemical pericarditis, or it's coronary vasospasm, or it is intercostal muscle strain, or it is rupture of the atherosclerotic plaques? The most likely mechanism, it is coronary vasospasm. The other syndrome characterized by coronary vasospasm, it is called Prinzmetal angina or variant angina. If he's asking about other scenario about variant angina or Prinzmetal angina, the answer, if he's asking the mechanism of chest pain in patient with Prinzmetal angina, the answer is going to be coronary vasospasm as well. So let's move on to question number 29. A 65-year-old man with type 2 diabetes mellitus, so type 2 diabetes mellitus, present to the outpatient diabetes clinic. He has background history of hypertension, myocardial infarction, diabetic retinopathy. He takes metformin. Metformin, it is antihyperglycemic agent, oral antihyperglycemic agent. Gliclazide, also it is oral antihyperglycemic agent, and long-acting. So he is on oral antihyperglycemic agent and on insulin injection. Urine test positive for microalbuminuria. This is indicator of early involvement of or early start of diabetic nephropathy, most likely with this positive microalbuminuria. His most recent HbA1c, it is 80 millimole. It's high. This represents that his diabetes mellitus is poorly controlled. This 80 millimole per mole, it is indicate that his diabetes mellitus is poorly controlled. I think it is in range of 11% in the old unit of HbA1c. So this is indicate poor compliance and poor control of diabetes mellitus. Blood test reveal eGFR of 68, which is within the normal range. So eGFR is still normal, but even though if the creatinine is normal and eGFR is normal, still the patient might have early stage of diabetic nephropathy, even with normal eGFR. And usually in the early stage of diabetic nephropathy, you will find the eGFR will be increased. This increasing, it's called hyperfiltration. This increasing the eGFR, it indicates the early stage of diabetic nephropathy. This has been stable for many years. Which of the following medication, he's asking about medication, would appropriate to commence to start in this presentation? I think the most appropriate here to start either ACE inhibitor or ARBs, because there is a strong evidence about nephroprotection of this medication in patients with diabetes mellitus and early stage of diabetic nephropathy. Amlodipine, it's calcium channel blocker. This is wrong. Bisoprolol, it is beta blocker, and this is wrong. L-troxin, it is thyroxine. There is no connection here, and this is absolutely wrong. Ramipril, this is, I think, the right answer for this patient, and ranitidine, it is H2 blocker, and this is wrong. So the right answer here, it is Ramipril. Question number 30, a 48-year-old lady has an ulcer in her right foot for the past 6 weeks. So So it is a chronic ulcer in the right foot. It is not painful, so it is painless ulcer. The ulcer is on the plantar aspect, in the sole of the foot, of the head of the first metatarsal. It has undermined edges, and the base of the ulcer is sloughy with a lot of exudate. So it seems to be an infective ulcer. She has a background history of type 1 diabetes mellitus. This is very important because one of the most common causes of foot ulcer is diabetes mellitus and diabetic neuropathy. So this is one of the most important differential. She as well, she had a history of hypertension. So here we have hypertension and obesity, and has 30-year history of smoking. So she is a heavy smoker. Her ankle brachial index is called API. On the foot is 0.91 with a digital brachial index of 0.74, which is reduced. And ankle brachial index, it's in the low side of the normal. So what type of the ulcer does this lady have? So type of ulcer, we have different type of ulcer. The ulcer, which in terms of the site of the ulcer that appears in the sole of the foot, the most common cause of this ulcer, it is diabetes mellitus or diabetic foot. The ulcer that can occurs in the heels, this is most likely it's a pressure ulcer, or it's called bed sores. The ulcer that appear in the tip of the toes, this is ischemic ulcer, or it's called arterial ulcer. And the ulcer that appear in where is the site of the medial malleolus, it is venous ulcer. This is here, it's venous ulcer. So here it's venous ulcer, here it is arterial or ischemic ulcer, here it is diabetic ulcer most likely, and here it's pressure, it's called bed sore PS. So what type of ulcer does this lady have? So given the scenario and the patient, the characteristic of the ulcer, it's painless ulcer. Painless character of the ulcer, it is very characteristic for diabetes mellitus. And the other things, the patient has reduced digital brachial index. This reduced digital brachial index, as well, this is represent some sort of low perfusion to the lower limb. So most likely, I think it is mixed between neuropathic and arterial ulcer. It's mixed between neuropathic and arterial ulcer. The answer number one, it's arterial alone. I think this is wrong. Mixed venous and arterial, I think it's wrong. There is a neuropathic component of this ulcer. Vasculitic ulcer, it's unlikely here. Venous ulcer, it's unlikely because the site of venous ulcer usually at the site of the medial malleolus. Vasculitis ulcer, usually it's appear in the chin of the leg, So here the question number 30. Question number 31 I will discuss in the next video. Thank you for watching this video.